Welcome back to the deep dive. Today we are undertaking a pretty massive mission,
We are.
a structured, comprehensive look at the assessment and management of inflammatory rheumatic disorders. And this isn't, just about a sore knee.
Not all.
This is about chronic, systemic conditions that really challenge a patient's independence, and they demand some of the most sophisticated nursing expertise out there.
That's exactly right. Our goal today is to synthesize that critical knowledge. We're going right to the core of the clinical content, helping you understand not just the names of these diseases, but the mechanisms that drive them.
And most importantly, the strategies to manage them.
The evidence-based strategies, yes.
Okay, so let's start by defining the landscape. When we say rheumatic diseases, we're casting a really wide net. This is much more than just simple wear and tear arthritis, correct?
Oh, absolutely. We're talking about a very diverse group of systemic conditions, and they're characterized by autoimmune, degenerative, and inflammatory processes.
And they affect everything. Joints, muscles.
Joints, muscles, soft tissues, all throughout the body. The common denominator, the thing that brings patients into the clinic, is almost always arthritis, which, just means inflammation of a joint, and the pain that goes with it. The chronic, often debilitating pain.
And the sheer scope of it is, well, it's intimidating. Over 100 different types of diseases fall under this umbrella.
A huge number.
But they all seem to converge on a similar set of pretty devastating outcomes for the patient.
They do. When you look at the patient experience, the consequences are severe. You have persistent pain, fatigue, profound limitations in mobility in their ADLs.
Sleep disturbances, I imagine.
Huge sleep disturbances, and a constant alteration of their self-image. And crucially, you have to remember, these conditions are systemic.
Right.
The inflammation isn't just in the knees and knuckles. It can progress to major organ failure, and it significantly increases mortality risk. We have to keep that systemic impact front and center.
So before we dive into the science, how do clinicians even begin to organize this enormous field? I know there are a couple of fundamental ways to classify them.
The classifications really help us focus the treatment. A simple clinical approach is just based on the number of joints involved. So monoarticular if it's a single joint.
Versus polyarticular.
Exactly, for multiple joints. But for our purpose today, for understanding the pathology, we really focus on separating the inflammatory conditions from the non-inflammatory ones, like osteoarthritis. Our deep dive is all about the inflammatory ones.
That makes perfect sense. Okay, let's nail down some essential terminology now so we can all be on the same page. We need to understand the sort of ebb and flow of these illnesses.
Yes. We use two key terms to describe that disease cycle. Exacerbation. That's the period when the symptoms flare up. They either occur dramatically or they just get much worse.
The flare-up.
The flare-up. And then remission is the opposite. That's the period when symptoms are reduced or maybe even absent. The goal of management is always to get the patient into remission and keep them there.
And when we talk about what's actually happening inside the joint, there's a crucial term for that destructive phase.
That would be pannus. You can think of pannus as this destructive, overgrown tissue. It's a proliferation of new synovial tissue that is just jam-packed with inflammatory cells.
And this is the stuff that does the actual damage.
This is the material that directly causes the cartilage and bone destruction in diseases like rheumatoid arthritis.
And the messengers that drive this whole process.
Those are the cytokines.
Oh.
These are cell signaling proteins. They're the immune system's text messages, basically. They are absolutely vital to regulating immune responses and inflammation. Sometimes they turn it up, sometimes they try to turn it down.
Okay, and finally, the prototype disease we'll be coming back to again.
Rheumatoid arthritis, or RA. It's a chronic systemic autoimmune disease, and it's defined by its symmetric joint involvement and its widespread features outside of the joints.
Okay, let's unpack that core pathophysiology. The textbook points to three distinct and often intertwined characteristics: inflammation, autoimmunity, and degeneration. To start with inflammation itself.
Right. Inflammation is this complex protective response that just goes completely haywire. It's immune-mediated, and it's supposed to happen when the body encounters something harmful, damaged cells, a pathogen, a foreign antigen.
It's meant to be a short-term cleanup crew.
Exactly. But in these chronic conditions, the process never shuts down, and it becomes actively destructive.
Can you walk us through that specific inflammatory cascade? I mean, where does the immune system first interact with the joint?
Okay, so it starts when an antigen stimulus activates T lymphocytes and monocytes. This leads to the production of immunoglobulin antibodies.
Okay.
Those antibodies then bind to the antigens, and they form what we call immune complexes.
Right.
And when specialized cells come along and engulf or phagocytize those immune complexes, that's when the real chain reaction kicks off.
So that phagocytosis, that cleanup process, is what initiates the visible signs. The swelling, the pain.
Exactly. The joint effusion, the edema, and the pain.
Wait, so this protective cleanup process actually turns into a destructive event for the joint. It's like calling in the bomb squad and they end up blowing up the whole building.
That is a perfect analogy. That active phagocytosis releases all these powerful chemical mediators. We see leukotrienes, which are messengers that call in even more white blood cells to the area.
Escalating the fight.
It just escalates the fight. We also see prostaglandins, which modify the inflammation. And crucially, you get these powerful enzymes released, like collagenase.
Collagenase. That sounds exactly like what it is, an enzyme that destroys collagen. And that's the structural support of the joint, isn't it?
It is, precisely. Collagenase begins to break down the joint's vital collagen structure, and this chemical damage leads to the edema, the swelling, and eventually the proliferation of the synovial membrane.
And if this were a normal injury, it would just stop there.
It would stop. The inflammation would resolve. But in chronic inflammation, the immune response becomes disorganized, it becomes persistent, and that leads directly to the formation of that destructive pannus tissue we just defined.
And the pannus, that overgrowth of inflamed tissue, is what seals the joint's fate.
It is the ultimate destroyer. The pannus infiltrates the joint space, causing irreversible destruction of the joint cartilage, and it leads to the erosion of the bone underneath.
Wow.
And that's what results in the characteristic loss of the joint surfaces, the misalignment, and the loss of motion.
So here's where it gets really, really important for understanding these diseases.
Yeah.
Autoimmunity. This is the central defining feature.
Autoimmunity is the definition of the self-attack. The body's immune system mistakenly recognizes its own tissues in the joints, lungs, heart, kidneys as foreign.
It sees itself as the enemy.
Yes. It targets them, and it triggers that entire destructive inflammatory process we just outlined against itself, leading to chronic pain and, inevitable tissue destruction.
And this really highlights why these diseases are so dangerous. We can't treat them like a sprained ankle because the attack is systemic.
That's the critical insight for nursing care. The inflammation and autoimmunity are not confined to the musculoskeletal system. They involve blood vessels, leading to dangerous conditions like vasculitis or arteritis.
Wow.
They impact the lungs, the heart, and the kidneys. The systemic reach is why a disease like lupus requires such vigilant, multi-organ monitoring.
And we know there's a strong genetic component underlying all of this.
Yes, we see a clear link to the human leukocyte antigen genes, or HLA genes. These genes are fundamental to how the immune system is regulated, and certain HLA subtypes are strongly associated with developing specific rheumatic diseases.
So it's like a genetic susceptibility that, when combined with some kind of environmental trigger, sets the whole thing off.
That's the model, exactly.
Okay, finally, let's quickly touch on the third characteristic. Degeneration, or as the source material refines it, degradation.
Yes, the source is clear that this is a metabolically active process, so degradation is a better word. It's still poorly understood, but the current theories really focus on how the cartilage structure fails.
And what are the main working theories on that?
Well, one major theory suggests that the failure is initiated by mechanical, genetic, or hormonal factors, maybe a prior injury. This leads to the initial degradation of the cartilage.
Okay.
And the resulting mechanical stress causes the bone underneath to stiffen. The counter theory proposes the opposite, that the bone stiffens first, and this stiffness then kicks off the cartilage degradation. Either way, the end result is the same: progressive, profound joint destruction.
Okay, moving firmly into the nursing realm now. Let's turn to assessment and diagnosis. What are the key clinical manifestations a nurse should be looking for right away?
Well, pain is the most frequent symptom that brings someone in, but the nurse needs a much more comprehensive view. You're looking for joint swelling, stiffness, especially that morning stiffness, limited range of movement, generalized weakness, and significant unrelenting fatigue.
Those are the red flags.
Those are the big red flags of inflammatory disease.
And the assessment has to start with a comprehensive health history, which really needs to go deep, since these are chronic conditions.
Oh, a thorough history is foundational. You need granular details on the onset of symptoms, how they've evolved, family history, past health history. And because it's a chronic disease, you have to capture the patient's perspective. What are their support systems? How do they perceive this condition's impact on their life?
That understanding really informs the self-management goals later on.
Completely.
Okay, we've got a critical checklist of observations here that a nurse must inspect. Let's walk through some of the highlights, especially the ones that seem, at first glance, unrelated to the joints, starting with just general observation.
Right. General inspection is dynamic. You're observing the patient's gait, their overall posture, their musculoskeletal structure the moment they walk in the room. You're noting any gross deformities or any abnormal way they move or guard a joint.
Then you move to the skin. Why is the skin so crucial in a joint disease?
The skin is a window into that systemic process. You look for rashes, like the ones with lupus. You check for erythema and warmth, which signal inflammation. Bruising might point to medication side effects like long-term steroids.
Which can also thin the skin.
Exactly. But the critical insight here is photosensitivity, that extreme reaction to sunlight. That is a major diagnostic clue for SLE or dermatomyositis.
What about the head and neck? Eyes, mouth, any sensory changes?
You have to assess for dryness. A gritty feeling in the eyes, a severely dry mouth that suggests a secondary Sjogren's syndrome. Decreased visual acuity must be investigated rapidly. It can be a complication of temporal arteritis or a side effect of medication.
Like tinnitus from medication toxicity.
Precisely. And in the mouth, you're looking for buccal or sublingual lesions, which might indicate vasculitis or Sjogren's.
Thinking systemically again, the cardiovascular and respiratory systems have to be monitored closely.
Absolutely. We ask about pleuritic pain, which can pop up in RA and SLE. We check for decreased chest expansion, which is really relevant in conditions like ankylosing spondylitis. And for circulation, you have to inspect for Raynaud's phenomenon.
That classic blanching of the fingers in the cold.
That's the one. And you need to check peripheral pulses because deficits can signal vascular involvement or just severe edema.
Okay, finally, let's get specific on the musculoskeletal assessment itself.
Here, inspection and palpation are vital. We're assessing for warmth, swelling, tenderness, and crucially, the pattern of involvement. Is it symmetric? Is it progressing from small joints to large ones? We assess range of motion.
And you're also looking for those extra-articular signs.
Yes, things like muscle atrophy or those classic non-tender subcutaneous nodules that are a hallmark of rheumatoid arthritis. A key indicator of disease activity is a decrease in muscle strength, especially grip strength.
And that leads right into the functional assessment, which is all about bridging those clinical findings to the patient's actual life.
The functional assessment is a critical marriage of patient history, what they tell you they struggle with, and your own observation as a nurse. You watch them do activities of daily living.
Like how they get out of a chair.
Exactly. But the most important nugget of knowledge here is recognizing patient adaptations. They might not report a deficit, but you see them bending over rather than raising their elbow to reach a glass. Those subconscious adaptations reveal the true extent of their functional limitation.
Okay, diagnosis relies heavily on lab work. Let's step through the most critical blood tests.
We start with the acute phase reactants. These are your inflammation gauges. The Erythrocyte Sedimentation Rate, or ESR, indicates rising inflammation. The faster the red cells settle, the greater the inflammatory activity.
And its partner, the CRP.
Right, the C-Reactive Protein, or CRP. A positive reading of CRP is a direct quantifiable indicator of active inflammation. These are vital for tracking how well treatment is working.
And of course, we have to check organ function, especially in systemic diseases like SLE.
Correct. Creatinine levels are crucial. An increase can signal kidney damage, especially in lupus nephritis or scleroderma. We also monitor uric acid, which, when elevated, confirms hyperuricemia and points to gout.
There's a clinical nuance there, though, right?
There is. During an acute gout flare, the uric acid level might actually look normal, only to spike back up after the attack subsides.
Okay, moving into the immunological evidence, the antibodies. The Antinuclear Antibody, or ANA test, is the big screening workhorse.
ANA positivity is highly sensitive for these diseases. It's positive in over 95% of SLE cases. The pattern of the test can give clues, and the titer indicates the intensity of the immune response. But for more specific markers,
You need something like anti-DNA.
Exactly. Anti-DNA and anti-escism are highly specific for SLE, and a high titer often correlates with increased disease activity.
And two final crucial markers, one for RA and one for tissue typing.
The Rheumatoid Factor, or RF, is positive in about 80% of RA patients, and its titer indicates the level of inflammation. It's important to remember, though, it can be positive in other diseases, too. And then you have the HLA-B27 antigen,
The genetic link?
the genetic link. Finding this antigen is strongly predictive. It's present in 80 to 90% of patients with ankylosing spondylitis and Reiter's syndrome.
So once the history, physical, and labs are done, imaging provides the structural context.
Imaging establishes your baseline and lets you track progression. X-rays are crucial for monitoring bone erosion over time. They're reproducible and cost-effective. Then you have CT scans, MRI, and arthrography for more detailed views of the soft tissue and cartilage, especially before you consider surgery.
Okay, let's transition now into general medical management. The chronic nature of these diseases makes management really an exercise in shared decision-making.
That shared decision-making is foundational. Management has to incorporate the patient's values, their preferences about side effects, their other comorbidities. Comprehensive education isn't a luxury, it's absolutely necessary for adherence.
And pharmacologic therapy is all about controlling symptoms, managing inflammation, and, most importantly, modifying the disease course itself. And that brings us to the linchpin of treatment, DMARDs.
DMARDs, disease-modifying antirheumatic drugs, are truly the immune weapons here. They suppress that destructive autoimmune response.
So they don't just treat symptoms.
No, they alter the disease progression, they induce remission, and crucially, they stop or at least decrease the physical tissue damage to the joints and the organs.
How do the two main classes of DMARDs differ in their approach?
We categorize them as non-biologic and biologic. Non-biologic DMARDs work more broadly across the immune system. The biologic DMARDs are the targeted specialty drugs. They're engineered to neutralize a single destructive component, like blocking the TNF-alpha cytokine or targeting specific B cells or T cells.
Okay, let's walk through the medication categories, focusing on the critical nursing safety points, starting with the oldest ones, salicylates and NSAIDs.
Salicylates, like aspirin, give you anti-inflammatory and analgesic effects. The nursing priority is simple. Give with food, milk, or a lot of water to mitigate the GI effects, and always assess for tinnitus, which signals toxicity or any signs of GI bleeding.
And the standard NSAIDs, like ibuprofen.
Standard NSAIDs carry risks. Again, administer with food and rigorously monitor for GI, renal, and cardiovascular adverse effects. The KOX2 inhibitors, like celecoxib, are a bit of a double-edged sword.
How so?
They reduce the risk of gastric bleeding, which is great, but the nurse must be vigilant for an increased risk of serious cardiovascular events like MI and stroke.
Moving on to the true disease modifiers. Antimalarials like hydroxychloroquine are often used early.
They are, but they're slow to act, often 2 to 4 months to show an effect. The absolute critical nursing consideration here is the risk of visual changes and retinopathy. Patients must have ophthalmologic exams every 6 to 12 months without fail.
And the most common first-line synthetic DMARD, the powerful immunosuppressive methotrexate.
Methotrexate is a cornerstone of RA treatment. The monitoring requirements are meticulous. CBC, liver enzymes, creatinine, all monitored regularly. Most crucially, methotrexate is highly teratogenic.
So patient education is key.
Nurses must provide strong counseling and advise patients of childbearing potential on strict contraceptive measures.
Finally, the newer targeted drugs, the biologic TNF blocking agents.
Right, like adalimumab and infliximab, they target TNF-alpha. But because they fundamentally suppress the immune response, the nursing considerations are paramount for patient safety.
Like testing for TB.
Patients must be tested for latent tuberculosis before starting treatment because the drug can reactivate it. We have to educate on the general infection risk and tell them to hold the medication if they develop a fever. And many patients self-inject, so teaching proper technique is critical.
And the fast-acting agents, corticosteroids like prednisone, used as a temporary measure.
They're powerful, quick anti-inflammatories. We often use them as a bridge to manage a severe flare while waiting for the slower DMARDs to kick in.
But there are a lot of side effects.
A long list. Cataracts, hyperglycemia, hypertension, a heightened risk of fractures. They have to be used at the lowest dose for the shortest time possible. And nurses must caution against repeating those intra-articular injections too often.
Okay, beyond the drugs, a holistic approach demands non-pharmacologic management. Let's look at simple tools, like heat.
Heat is highly effective for relieving stiffness, pain, and muscle spasm. Whether it's a warm bath or a paraffin treatment for small joints, the max benefit occurs within about 20 minutes. A great tip for patients is to apply heat before their physical therapy session to maximize their range of motion.
Assistive devices are also essential in reducing that biomechanical stress.
Exactly. Braces, splints, canes, crutches, they all share the common goal of easing pain by limiting movement or weight-bearing stress on an inflamed joint. The nurse has to encourage consistent use of these.
Exercise is vital, but the program has to be carefully managed,
Well,
right?
it does. There are four main components. Range of motion exercises maintain flexibility. The caution here is just to reduce repetitions if the joint is acutely inflamed.
And what about building strength without aggravating the joints?
That's where isometric exercise comes in. It improves muscle tone and static endurance. But nurses need to monitor blood pressure during these, as isometrics can acutely raise it.
Okay.
Then you have dynamic exercise to improve dynamic strength, but you have to avoid excessive stress on unstable joints. And finally, aerobic exercise for cardiovascular fitness, moderate intensity, 20 to 30 minutes, 3 to 5 days a week.
And the highly effective, low-impact option, pool exercise.
Pool exercise is fantastic. The water provides buoyancy that supports movement and reduces joint compression, and the warmth relaxes muscles. You just have to make sure the patient is safe with non-slip footwear.
Finally, addressing sleep is paramount. Chronic pain and stiffness make sleep deprivation almost a certainty.
And that sleep disruption just fuels the fatigue and pain cycle. Nurses should teach rigorous sleep hygiene, consistent sleep-wake times, avoiding caffeine and alcohol before bed, a quiet environment, relaxation exercises. Sometimes a short-term, low-dose antidepressant like amitriptyline can help reestablish a healthy sleep pattern.
Now we arise at the core of nursing interventions and education. The model of care here relies entirely on fostering self-management.
Self-management is the key to quality of life in these chronic diseases. And nurses can use standardized tools like the Arthritis Self-Management Assessment Tool, or ASMAT, which systematically evaluates the patient's ability to handle all the different tasks.
So it helps you target the education.
Exactly. You target it where it's needed most.
Let's focus on the critical thinking behind the plan of care. We can't just list interventions. We need to prioritize. Let's start with managing pain.
Okay. The nursing plan requires individualizing pain control. So yes, you're administering medications on a schedule, but you're also coupling that with non-pharmacologic comfort measures, heat, cold, massage, splints.
And the goal?
The expected outcome shows the patient taking control. They can identify their pain triggers, and they use management strategies before the pain becomes overwhelming.
Next, managing fatigue, which patients often say is even worse than the pain.
Nurses need to validate that fatigue. It's real, and it's directly related to the disease's inflammatory state. We intervene by developing sleep routines and rigorously teaching energy conservation techniques, pacing, prioritizing rest periods.
So the goal is for them to build this into their daily life.
Right. The expected outcome is that the patient incorporates these time management strategies into their daily routine.
How do nurses promote mobility when joint integrity is compromised?
We have to encourage the patient to verbalize their limitations, assess their needs for PT or OT, and reinforce the importance of daily ROM exercises and safe footwear. Promoting assistive devices is vital. The outcome is measurable. The patient uses the right techniques and equipment to aid their mobility.
And supporting self-care deficits.
This is all about adaptation and independence. The nurse helps the patient identify their deficits and then introduces assistive devices, long-handled reachers, special utensils, while incorporating those energy conservation principles. The outcome is the patient finding alternative, successful methods for meeting their own needs.
Okay, finally, the critical psychological factors. Coping with altered self-concept and body image.
This requires empathy and therapeutic communication. We encourage the patient to express their fears and frustrations about body changes and loss of function. The nurse helps them identify elements of control over their symptoms, which is incredibly empowering.
What's the outcome you're looking for?
Psychological healing. The patient verbalizes that these changes in self-concept are a normal response to chronic illness, and they actively enlist social support.
The final nursing priority is ensuring adherence and monitoring, especially with those high-risk DMARDs.
Adherence is life-saving. The nurse has to perform periodic clinical and lab assessments to catch side effects early, and the education must be crystal clear about self-administration, side effects, and the monitoring that's required.
Okay, moving to gerontologic considerations. Older adults face a really complicated interplay of factors.
They do. Musculoskeletal problems are the #1 health complaint in older adults. Now, you overlay this with disability, cognitive changes, existing comorbidities like heart disease. It severely complicates diagnosis and care.
And those other conditions can mask the rheumatic disease symptoms.
Exactly, leading to misdiagnosis or delayed treatment.
And assessing pain itself in this demographic can be a real challenge.
It is, especially since older adults, particularly men, can be very reluctant to communicate their pain unless you ask directly. So nurses have to rely on behavioral clues, changes in gait, guarding motions, unusual joint flexion. And untreated pain, it devastates their quality of life.
And pharmacologic safety has to be paramount because of age-related physiological changes.
Right. Decreased renal and hepatic function significantly prolongs the effects of medications. So, for instance, NSAIDs carry a much higher risk of GI bleed and cardiovascular toxicity in older adults.
So you might try acetaminophen first.
You might. And nurses also have to watch for overtreatment, like repeating corticosteroid injections too often, which can weaken the joint structures.
And there's that psychological hurdle of using adaptive tools.
That's a major barrier. Many older adults see symptoms as just an inevitable consequence of aging. More critically, depression and body image concerns can make them resist using assistive devices. They see a cane or a splint as evidence of aging.
Instead of a tool for independence.
Exactly, and nurses need to proactively reframe that perception for them.
Okay, now let's launch into the specific systemic disorders, starting with the classic. Rheumatoid arthritis, or RA.
RA is the prototype systemic autoimmune disease. It affects 1 to 2% of people globally, with women being 3 times more likely to get it. Onset is typically mid-adulthood, but we also see elderly onset RA after 65.
And the risk factors.
Family history, obesity, and significantly smoking.
We know the general pathophysiology, but what makes the RA process unique?
The initial autoimmune reaction is specifically in the synovial tissue. This leads to that intense proliferation of inflammatory cells and the formation of the destructive pannus tissue. And the systemic effects go way beyond the joints.
Like the cardiovascular risk.
The chronic inflammation interferes with HDL production, which massively implicates RA patients in developing arteriosclerosis and cardiovascular disease. Neuropathies and nerve compression are also common.
And the diagnosis isn't just based on presentation. It requires meeting specific criteria.
Correct. The Accreal scoring system. You need a score of 6 or greater based on 4 things. The number and size of joints involved, serology like RF or ACPA, acute phase reactants, and a symptom duration greater than 6 weeks.
What are the clinical hallmarks that should alert a nurse to potential RA?
Classic RA presents with symmetric joint pain, swelling, and warmth. And that's accompanied by morning stiffness that lasts longer than 1 hour. Usually starts in the small joints, hands, wrists, feet, and it progresses symmetrically.
And the devastating complications as the disease advances.
The destruction leads to classic deformities. Things like ulnar deviation, where the fingers drift away from the midline, and the swan neck deformity, subluxation, is common.
And the extra-articular features.
Fatigue, fever, and those non-tender rheumatoid nodules, which appear over bony prominences and are exclusive to RF-positive patients.
Medical management stresses aggressive, early treatment to prevent that irreversible damage.
The imperative is to start DMARDs within 3 months of diagnosis. Methotrexate is the preferred synthetic agent. Biologic DMARDs are generally reserved for patients who haven't responded to the synthetics, and corticosteroids are only a short-term bridge.
And for established RA, combination therapy becomes common. What about surgery?
Combination therapy is very common, yes. Surgery is strictly for reconstruction and palliation, synovectomy, arthrodesis, joint replacement. But the critical note here, surgery is never performed during an acute exacerbation because of the intense inflammation.
We should also touch on obesity, which is highly prevalent in RA patients.
It's a huge issue. Obesity directly and negatively affects disease progression and quality of life. Weight management is essential. Nurses should be counseling on a healthy, calorie-restricted diet while making sure they get enough protein, iron, and vitamins.
Next, let's turn to systemic lupus erythematosus, or SLE, the classic multi-organ autoimmune disorder.
SLE affects nearly every organ system. It occurs much more frequently in women, 4 to 12 times more often, and is disproportionately prevalent in African Americans, Hispanics, Latinos, and Asians.
What is the specific pathological mechanism in SLE that causes such widespread destruction?
The immune system launches an attack against the components of the cell nucleus. B cells overproduce antibodies, and these antigen-antibody complexes circulate and get trapped in the capillaries of visceral structures, the kidneys, the heart, the brain, where they cause inflammation and destroy host cells.
And what are the environmental triggers known to precipitate these flares?
It's multifactorial. Genetic and hormonal factors are key, but environment plays a huge role. Triggers include UV rays, sunlight, even fluorescent light infections, significant stress, and certain drugs. And we have to counsel patients on smoking cessation.
Why smoking specifically?
It inhibits drug effectiveness and increases their already high risk of cardiovascular disease.
The clinical course is characterized by remission and acute flares. What are the common symptoms?
Early symptoms are often vague: fever, fatigue, joint pain, rashes. But the disease is defined by its multisystemic nature. We worry about lupus nephritis in the kidneys, CNS involvement leading to psychosis or seizures, and cardiac involvement, with pericarditis being the most common finding.
And the cutaneous manifestations are often visually classic for SLE.
Up to 85% of patients have skin involvement. We look for the chronic discoid rash, which can cause scarring, and the hallmark sign, the acute butterfly rash across the bridge of the nose and cheeks. These lesions absolutely worsen during flares and after UV exposure.
And how does serology provide definitive proof of SLE?
ANA is positive in over 95%, so it's a great screening tool. But for diagnosis, we rely on the highly specific antibodies, anti-DNA, and anti-HISM. Monitoring the anti-DNA titer is vital, as a high titer suggests increased disease activity.
Management is focused on preventing organ loss. What are the key pharmacologic tools?
Targeted therapy includes the monoclonal antibody belimumab. The nursing alert there is that live vaccines are contraindicated 30 days prior, and corticosteroids are used heavily. Topical for skin, low oral dose for minor activity, and high dose IV for major organ-threatening disease.
And the major risk with all that steroid use?
The increased risk of osteoporosis and fractures. Nurses must ensure baseline bone mineral density testing at diagnosis and every 2 years on long-term steroids, plus supplementation with calcium, vitamin D, and weight-bearing exercise.
So what are the critical nursing education points for the SLE patient?
Managing fatigue, impaired skin integrity, and body image disturbance are key. But patient safety hinges on education, rigorous avoidance of sun and UV light exposure, counseling on smoking cessation, and strict adherence to the osteoporosis screening and supplement regimen.
Okay, let's synthesize a few of the related complex disorders now, starting with primary Sjogren's syndrome.
SS is a systemic disease where lymphocytic infiltration causes the failure of the lacrimal and salivary glands. It can be secondary to RA or SLE, or it can be primary.
And the key manifestations are all about dryness.
Pure dryness. The defining symptoms are choroidoconjunctivitis sicca, that profound dry eye with a gritty feeling, and xerostomia, the dry mouth that makes it hard to swallow or speak.
So management is entirely symptomatic.
It is. Artificial tears, moisturizing gels, punctum plugs, drugs like pilocarpine to increase salivary flow. Nurses must counsel patients to avoid drying agents, spicy foods, alcohol, anticholinergic drugs. The priority is meticulous ocular care to prevent corneal damage and screening for depression.
Next, scleroderma, or systemic sclerosis. This involves a profound hardening of tissues.
Scleroderma is rare. It's characterized by a massive, excessive accumulation of insoluble collagen in the tissues. The skin becomes smooth, taut, and shiny. It loses all elasticity. The face can become mask-like. We call it stone faces.
And the internal organ involvement sounds truly dangerous.
The hardening process affects internal structures like the esophagus, the lungs, and critically the kidneys, often causing malignant hypertension.
The CREST syndrome helps categorize a specific subtype, right?
CREST is the mnemonic for a limited form: calcinosis, Raynaud's phenomenon, esophageal dysmobility, sclerodactyly, and telangiectasia. Management is supportive. ACE inhibitors are critical for the kidney involvement, and nurses prioritize meticulous skin care and preventing the effects of Raynaud's.
Okay, moving on to polymyositis, an inflammatory condition focusing just on the muscles.
Polymyositis is an idiopathic inflammatory myopathy. The hallmark symptom is the slow, insidious onset of proximal muscle weakness.
So difficulty with things like getting out of a chair or climbing stairs.
Exactly. Or holding objects overhead. Myalgia, or muscle tenderness, affects about half of the patients. Corticosteroid therapy is the mainstay of treatment, with very gradual physical therapy. The nursing priority is addressing those severe functional deficits.
We also have the related disorders, polymyalgia rheumatica, PMR, and giant cell arteritis, GCA, which target older adults.
These are a spectrum of vasculitis affecting individuals over 50. PMR presents with severe aching and stiffness in the neck, shoulder, and pelvic girdle, often worst in the morning.
And the high-stakes diagnosis, GCA, or temporal arteritis.
GCA is a dangerous vasculitis of medium and large arteries. Classic symptoms are new-onset headaches, jaw claudication, and most critically, acute vision changes.
This is a massive quality and safety nursing alert. What is the life-saving management for GCA?
Immediate, rapid initiation of high-dose corticosteroids. Strict adherence is critical because untreated GCA carries a severe risk of irreversible blindness or stroke.
Wow.
The nurse has to emphasize this risk, and because of the high steroid dose, bone health must be rigorously protected.
Okay, shifting now to the spondyloarthropathies. These are defined by inflammation at the tendon and ligament attachment sites, the entheses.
Yes, this family of diseases, ankylosing spondylitis, reactive arthritis, and psoriatic arthritis, they share common features. Inflammation at the entheses, sacroiliac joint involvement, a strong link to the HLA-B27 marker, and increased cardiovascular risk.
Let's focus on ankylosing spondylitis, the chronic inflammation of the spine.
As S progressively fuses the spine, it leads to profound rigidity, decreased mobility, and often severe kyphosis, that stooped forward bent posture. Management involves NSAIDs and biologics, but crucially, excellent posture and a rigorous exercise program are essential.
And the other two common types?
Reactive arthritis is triggered by a prior GI or GU infection. It's the classic triad of urethritis, arthritis, and conjunctivitis. And psoriatic arthritis is inflammatory arthritis associated with psoriasis. The back pain uniquely improves with activity and is worse at night.
Finally, let's look at gout, a purely metabolic disorder that is the most common form of inflammatory arthritis.
Gout prevalence is significant and rising. It affects men 3 to 4 times more often. The risk factors are all metabolic: age, high BMI, excessive alcohol, hypertension, diuretic use.
Gout is defined by hyperuricemia. How does uric acid, a pure byproduct, cause that explosive inflammation?
Serum uric acid levels rise above 6.8 mg/dL. The acute attack happens when macrophages phagocytize these needle-like urate crystals, which then triggers a massive release of IL-1B, leading to intense inflammation. Triggers are often alcohol and red meat.
And gout progresses through 4 stages.
Asymptomatic hyperuricemia first. Then, the acute gouty arthritis attack, abrupt, often at night, commonly in the great toe. This is followed by intercritical gout, the symptom-free period. And finally, chronic tophaceous gout with visible accumulations of urate crystals called tophi.
And management is highly dependent on the stage. What's the critical difference between acute and maintenance therapy?
Diagnosis is confirmed by synovial fluid analysis. For acute attacks, we use powerful anti-inflammatories, colchicine, NSAIDs, or corticosteroids. For maintenance uric acid lowering therapy, we use agents like allopurinol.
And here's the crucial nursing rule.
The crucial rule: maintenance drugs should never be started or have their dose increased during an active flare, as this can actually worsen the attack.
So what are the nursing priorities for gout education?
Education must be comprehensive because adherence is often poor once the acute pain is gone. We teach them to restrict purine-rich foods, limit alcohol, and strive for a normal body weight. Above all, nurses must stress that continuous medication adherence is the only way to prevent more damaging attacks.
Our final condition is fibromyalgia, a chronic pain syndrome that is complex and often misunderstood.
Fibromyalgia involves chronic fatigue, generalized muscle aching, stiffness, and sleep disturbances. The current theory suggests the pain is neurogenic. It's an abnormal processing of pain signals in the CNS. You can think of it as the central nervous system's volume control for pain being turned up way too high.
How do we screen for it if standard diagnostics are usually normal?
The diagnosis is largely based on symptoms, but useful screening includes asking if the patient has a persistent deep aching all over my body and assessing for tenderness when you pinch the Achilles tendon.
And management focuses on multiple symptoms at once: pain, mood, and sleep.
Right. NSAIDs for the aching. Addressing the chronic sleep deficit is vital, using tricyclic antidepressants like amitriptyline and strict sleep hygiene. Other effective agents include SNRIs, muscle relaxants, and anticonvulsants. Cognitive behavioral therapy is also highly recommended.
And the nursing priority?
Emotional and psychological support, validating the patient's experience. They often feel their invisible symptoms have not been taken seriously by the healthcare system.
So what does this all mean? We've covered a massive spectrum, from the targeted autoimmune destruction of RA and SLE to the vasculitis of GCA and the crystal buildup of gout. But for the nurse, the focus keeps returning to the core functional priorities.
Absolutely. The powerful synthesis here is that regardless of the specific diagnosis, the fundamental plan of nursing care always addresses the same 5 functional challenges: pain management, fatigue management, promoting mobility, addressing self-care deficits, and ensuring psycho-emotional coping and adherence. That structured approach really anchors your care.
Let's nail down the 3 key nursing takeaways for the learner listening today.
Okay. First, remember the necessity of recognizing the systemic involvement beyond the joints. You are managing conditions with major mortality implications. Cardiovascular risk in RA, potential blindness in GCA, and renal failure in SLE.
Right.
Second, care has to be individualized, holistic, and multidisciplinary, combining precise pharmacology with PT, OT, and pain management specialists.
And the third takeaway focuses on patient education and safety.
The nurse's role as educator is critical for self-management, safety, and adherence. This means communicating those high-stakes warnings like UV avoidance in SLE, the signs of infection risk from DMARDs, and the strict necessity of adherence to GCA medication to prevent blindness. The nurse is the essential conduit between complex medical science and the patient's ability to safely live their life.
Thank you for guiding us through this incredibly complex material with such clarity.
My pleasure.
I want to leave you with one final provocative thought to consider. Given the high prevalence of depression, fatigue, and altered self-concept across all these chronic inflammatory diseases, how can nurses, in every single patient interaction, shift the perception of adaptive equipment, canes, splints, specialized tools, from being viewed by the patient as a sign of failure or aging, to being viewed as a tool that actively promotes independence and self-efficacy? That reframing is truly a crucial step in patient-centered, empowering care.
Indeed. It's about empowering the patient, not labeling them.
That's it for this deep dive. We hope this has provided you with a clear, structured roadmap for managing these complex patients.